Next, we have the cataract coach himself, Dr. Uday Devgan, who's going to be talking about how pupil size and centration affects trifocal and EDOF IOLs.
And I'll be properly American. I will not be 1 minute over time. Just hit play. Where's my video? Pull up the video and hit play. Video. This side, okay. There it is. Just hit play. Yeah, it's just one MPEG file.
CataractCoach.com. Effective pupil size for extended depth of focus.
Go for it. You used up your minute. I know. Don't worry. The video is actually less than my allotted time. So hit play, please. Make sure it starts.
And monofocal plus
All right,
IOL.
the effective pupil size.
We
for
know
EDOF
pupil
and
size is
monofocal plus
important
lenses.
for
We all
depth
know
of field.
A smaller pupil is
And
a
the
much
depth of
wider
field is
depth of
wider
field.
when we have a
Simple
smaller
optics
pupil,
from way
much
back
like a
when
camera
we were all
with a
young.
smaller
And so
aperture
we know
giving
that
us
you can take
that
into
wide
account,
depth of
very
field.
importantly, for
The
patients
larger
who are
pupil is going to
having
give us
cataract
a
surgery,
narrower
you
depth
need
of
to
field,
know
but of
what
course
is
lets
here.
in more light
There's
for
no
dim
audio
lighting
in the video. I'm
situations.
doing the audio
You've all
live.
seen patients in your clinic with
But
small
this also
pupils
applies
and a
when we use
monofocal
any
lens,
kind
and
of
yet they have no need for
specialized
glasses
EDOF
near or far.
lenses or monofocal plus lenses. So, here are the ones that are available in the USA. We only have 3. We have the Vivity, we have the Symphony, and we have the Apthera. Now, obviously, we know the Vivity works by that central 2.2 millimeter element that changes the wave shaping. That causes a little bit loss of contrast, and it gives about a 1.5 diopter range. But remember, it's that central 2.2. So if you have a patient with a larger 4.5 millimeter pupil, only a quarter of the light's going through that central zone. Whereas if you have a patient with a smaller pupil, like 80% of the light's going through that central zone. This is also why we learned at the beginning, these patients end up with a myopic outcome. You aim for plano, they ended up minus 0.5, minus 0.75. So now with a small pupil in this lens, we aim for a little hyper in order to achieve plano. Because again, most of their central optical zone is taken up by this 2.2 millimeter focusing element. So this is really important. This will help you actually nail your target. You have to see for this lens, what's the pupil size. Now the Symphony is another good lens. That has rings in it, diffractive EDOF lenses, about the same 1.5 diopter range, but it's accomplished through diffractive rings. And all these rings here, it's not pupil dependent so much, because no matter what, you're getting light going through all of these rings here. And these ones, you can aim for plano to get plano. So with the Symphony lens, which has probably the worst dysphotopsias, however, I don't think you need to change anything depending on pupil size, including your refractive outcomes. And then the third lens that we have available is the Apthera IC8, which is a small aperture lens here, and it gives about the same 1.5 diopters of range. But of course, because it's a small aperture, you have loss of light. That's the side effect. So that central zone is actually only 1.36 millimeters on the IOL plane, and so we can do the math to see, well, how much light is transmitted to the eye, to the retina, depending on the pupil size. We can just do some simple geometry way back when we were kids, and you can see at a large pupil, you get most of the light going through, but if you have a patient with a 3 millimeter pupil to begin with this light, you may block out about 80% of the incoming light. So obviously, there's no way of cheating physics. So even if you love one lens over the other, always keep in mind the concept of the physics of it behind the lens. Now this lens, obviously, we talked about with a 4.5 millimeter pupil, you're going to lose about 40% of light. And these lenses, if you have a 3 millimeter pupil, you're going to lose about 80% of the light. And so in both these situations, though, however, you aim for a little bit of minus post-op. And the reason is you'll get a little bit more range, because obviously the pinhole effect, if your patient ends up minus 0.5, minus 0.75 with the pinhole, they're still able to see 6.6 at distance. So now let's talk about the Eyehance. The Eyehance is not, at least in the USA, not an EDOF lens. It does not meet the criteria. It's only a central 1 millimeter zone on an optic that's overall 6 millimeters and 5 millimeters of focusing. So because of that, it has a very modest effect. This is from J&J's own data. And you can see it's a very, very mild bump in purple there with the Eyehance at 1 meter. Very mild, at a meter. That's not here, that's a meter. I can't reach a meter even. So keep this in mind, and you say, well, I have some patients who are so happy. Well, of course, with a 4.5 millimeter pupil and this 1 millimeter zone, only 5% of light goes to that central zone. That's not gonna have any effect. With a 2.5 millimeter pupil, better, now 16% of light goes to the central zone, plus you have the benefit of the smaller pupil giving you better depth of focus, depth of field. So here's another case. Look at the patient here. The IOLs in the eye, nicely centered up, sealing up the incision here. And if you look carefully, you'll see this is, again, an EDOF lens with a central focusing element there. This is that Vivity lens. I don't work for any of the companies anymore. Now my disclosure list only includes companies in which I have an ownership stake. And I don't own anything in B&L, Alcon, or J&J, so I don't work with any of them. But you can see here at the end of the case here, that's a beautiful centration, and that's obviously important as well, to line this lens up with the Purkinje images and, of course, the pupil as well. And these days we can do this with augmented reality with some of our fancier operating theater microscopes. And so I want you to keep this in mind when you're doing all this stuff. Think about pupil size. Someone asked me yesterday about a patient I talked about in Cataract Coach who is a +4 hyperope, and I put in monofocal IOLs and Plano OU, and they said, why didn't you do it trifocal? I said, I didn't need to. The patient naturally has, it was a woman of Indian origin here in Beverly Hills, has naturally small pupils, as you know. So with her 2mm pupils, even with a monofocal lens, she had a fantastic range of vision because of this. So again, at the end of the day, I think one more parameter which we have to examine for all our patients is, what's pupil size? That actually is important. For us to deliver a truly refractive cataract surgical outcome, we have to take into account pupil size. And finally, again, for aiming your refractive target, for Vivity, remember, if it's a smaller pupil, aim for +0.5 so you don't end up myopic surprise. Apthera, I like to aim for a little bit of minus in all eyes because you have the benefit of the pinhole pupil. So that's kind of the summary here. We'll skip here to the very end, and then I will be happy to field a question, or we can move on.
Is there a pupillary size, say mesopic pupil of 2 mm, which sometimes extremely senile could be adult people could be having it, beyond which any of these multifocals or premium intraocular lenses don't work, and all of them work like a monofocal lens?
Right, that makes a lot of sense. If you have a lens that has concentric target, right, that has the diffractive rings, and the patient, even in nighttime, has a 2mm pupil, you're not going to get the benefit of the multifocal. So I will not put a multifocal in someone who naturally has really small pupils, because they'll be thrilled with a monofocal. I'm not in the game of selling lenses. I'm in the game of giving the patient the refractive outcome that's going to make them happy, regardless of the lens selected.
So what about a EDOF like a monofocal plus or a VVT?
So a monofocal plus may be a benefit. With a 2mm pupil, that central 1mm bump may have even more benefit. Or a Vivity lens, again, be careful because that central zone of the Vivity is 2.2mm, so they're going to end up a little myopic. They're going to see essentially only through that central zone. So just be careful on the targeting.
And just a last question. We are just getting the IC8 in the Indian market, and we don't have much experience with it. How's the uptake abroad, and where exactly we are all concerned about very little light going in, and
well, US FDA approval is only for the non-dominant eye, with the other eye getting a monofocal. That's the wording of the US approval. And that's how I use it too. I don't ever put it bilateral. I think that's a mistake. And so in that lens, just be careful. It also requires a bigger incision. And if you need to YAG them, you have to YAG a very special way outside of that central zone.
Thank you, Coach.
Okay.